So, good evening. Welcome to the Tuesday Masterclass sessions from the Department of Critical Care Medicine at Yashoda Hospital, Hitech City. So, as a part of the Masterclass today, this Tuesday, we bring across another new topic, that is Neutropenic Sepsis. And to moderate this, we have seasoned examiners, Dr. Yash Javeri sir, who is a Director of Critical Care and Emergency Medicine at Regency Health, Lucknow. Thank you for joining us, sir.
Thank you, Dr. Ravi. Thank you, Dr. Venkat.
Good to see you back, sir. And we also do have Dr. Mona Lisa Sahu, madam, who is an infectious disease consultant at Yashoda Hospital, Secunderabad. So we want to have a perspective of both the intensivist as well as the infectious diseases consultant view on how to manage this neutropenic sepsis. So to present this, we have Dr. Pratyusha and Dr. Shilpa, who are DRNB critical care medicine residents from Fortis Hospitals, Bannerghatta, Bangalore, presenting us. Thank you for presenting this case, Pratyusha and Shilpa. So now you can start presenting the case.
Just a few words, Dr. Ravi. Good evening,
Yes,
Dr. Pratyusha, Dr. Shilpa. We'll go slow and point-wise, small, like MBBS case presentation. We'll do like that, very slow. We'll bother you in between, so don't get bothered. Okay, we can start. Thank you.
Good evening, sir. Good evening, sir. Good evening, ma'am. So today we are going to present this neutropenic sepsis. So we had a 78-year-old male, his name is Mr. X. He presented to our emergency with complaints of shortness of breath, which is graded MMRC grade 4. So his WHO performance score is 3. So patient had a sudden onset of shortness of breath, which is gradually progressive. It was from MMRC grade 2 to grade 4 within 4 days. It was associated with fatigue, decreased appetite, and reduced activity. There was no complaints of any fever, cough, cold, or neither any chest pain, orthopnea, or PND. There's no history of any allergies. There's no travel history, or there is no history of any contact with similar complaints among the family members.
Yeah, 1 second. Can you elaborate on MMRC grading? And
Yes.
how does it help us in critical care? A patient coming to emergency with MMRC grade 2, grade 3. How can it help in triaging?
Yes. So this MMRC stands for Modified Medical Research Council, sir. So it has a grading from 0 to 4. The 0 indicates that the patient can be able to do any kind of strenuous activity. Grade 1 indicates there is no strenuous activity, but uphill, he has breathing difficulty while he goes uphill. And grade 2 will be like he will not be able to compete with his peers with the normal flat walking. And grade 3 is within 100 yards, he feels breathless while he walks within 100 yards limit. And grade 4 is he has shortness of breath even at rest, sir.
Yeah.
So according as per this, we can know the severity of his clinical complaints. So usually when the complaints grade 3 to 4 usually might require an ICU care. So that is the reason we do with MMRC grade.
Yeah. So always remember baseline MMRC grade or WHO performance status is relatively poor. The risk is high, and while triaging such patients, we should be thinking about keeping them in a monitored area. Could be HDU, could be ICU to start with. Right. Thank you.
So his past history, he is the known case of multiple myeloma, sir. It is an IgG kappa type, which is transplant ineligible. This was diagnosed in February 2020. So after that, he underwent a palliative radiotherapy to his lumbosacral spine. This was in 2021. And he also underwent chemotherapy with 6 cycles of Cybot, followed by lenalidomide. That was in 2020. Post that, there was a partial response of his disease condition. And again, there was a comprehensive myeloma panel checked on February 2025, that's the year, which suggests of a relapse refractory multiple myeloma. So after this, patient underwent a PET CT scan in the month of March, which suggested of a disease progression. Apart from that, he is also a known case of diabetic mellitus. He had a diabetic neuropathy, acute and chronic kidney disease, with his baseline creatinine being around 2.2, sir. So currently, he had a medical history of he takes an injection daratumab that is monthly, and he's been on Texa 8 mg, which is taken weekly. lenalidomide 10 mg and denosumab 6 months once he's been taking, and bortezomib. So this daratumumab and bortezomib, the last doses which he received was on 18th of August. Patient presented to us on 23rd of August. When he comes to personal history, he's mixed diet. There is no smoking or alcohol habits.
So while you have this past history, what is very peculiar in this history which correlates with your case, and how will you treat this patient differently from others, especially myeloma and lenalidomide?
So he is an immunocompromised patient, sir.
Yeah.
That's one thing. So we can expect there could be a neutropenic sepsis for this patient.
Very true.
So patient requires an isolation care, and we need to the infection also, it can be significant, like severity of the infection will be severe in this kind of patients. So this kind of patients will require ICU care. And
so multiple myeloma itself, it acts on the bone marrow. So there'll be a bone marrow suppression per se from the disease. In addition to that, the medicines he is on, so DEXA, lenalidomide, all these itself will cause immunosuppression. So patient is immunocompromised with these medications and as well as the disease.
So while you triage such patient, it is our duty to decide on the site of care also, as we discussed earlier, and if isolation precautions are required, because this patient should not get another hospital-acquired infection. So it will be very particular to admit such patients in an isolation facility. What are the common side effects of this drug? Whenever you have some unusual drug, lenalidomide also we don't see very frequently, you should always read about that drug. At times it will point towards the correct diagnosis. So lenalidomide, what are the common side effects you are aware of? One you told? One you already told?
Can have neutropenia can happen, sir.
Neutropenia, anemia, thrombocytopenia, and what else?
So they can have
common side effect is thrombosis, DVT, at times acute coronary syndrome. So these are common side effects related to ICU practice. So always remember this, right?
So in the ER, patient was conscious, coherent. He was tachypneic with saturating 88% on room air with respiratory rate of 35. Heart rate was about 120. BP was 80-60. Patient was in shock. Afebrile at the time of presenting in the ER. Respiratory wise, bilateral creps were present and air entry was equal on both sides. CVS wise, S1 and S2 was hard. Patient GCS CNS wise, GCS was 15/15. Patient had no neurological deficit. So GRBS was done. It was showing, it was 150 mg per dl. And the VBG actually was done in the ER. It was showing a metabolic acidosis with minus 8.8 of base excess with 7.39 pH with lactates of 2.8 millimoles. So with the respiratory distress, patient was started on NIV. And chest X-ray was done, which was showing bilateral infiltrates. So he was 2 sets of blood cultures was taken, started on IV fluids, meropenem, hydrocortisone, nebulizations, and he was shifted to ICU for further medical management.
So what is your preliminary diagnosis at this point?
With this primary diagnosis, it looks like a patient came with acute hypoxic respiratory failure in shock. And the source of infection seems to be the lung. So acute respiratory failure with shock, with septic shock.
With
probably
severe community-acquired pneumonia, most likely.
Severe community-acquired pneumonia.
So this is septic shock, acute type 1 respiratory failure, probably neutropenic, and severe community-acquired pneumonia. Dr. Mona Lisa, you want to add something at your field?
So at this, like having this history of the patient in the mind and the clinical presentation such, so what would be the probable pathogens that you would suspect in this patient causing this?
Yeah, they can be, most common is the viral, ma'am. So viral can be influenza.
Sorry, but common things common. First will be always gram-negative bacteria. Common things are common.
Gram-negative bacteria, which includes Enterobacteriaceae, and the other thing is Pseudomonas. We need to
So here a patient can come with bacterial is the most common cause of infection. So the usual community acquired pneumonia itself can be happening in the patient. So Streptococcus pneumonia, H influenza, etc. are all there. In addition to that, because the patient has a recent hospital admission and chances of MDR, so gram-negative also and are more susceptible to that. Patient was also in shock. So gram-positive cover also might be required for the patient. So
what are the most common organisms in the Indian epidemiology that we come across?
For community-acquired pneumonia?
No, for this presentation.
So in this case, since there's a MDR, gram-negative organisms are the most common presentation in the Indian setting.
Followed by, other than the gram-negative ones, what would we cover for?
Gram-positive cover also.
Which are the common ones that you come across?
Streptococcus and MRSA also, methicillin resistant strep.
Yeah, if it is a case of sepsis, even the coagulase negative staphylococcus also are common in neutropenic patients. We should keep that in mind as well. Okay.
And atypical organisms also could cause, especially in immunocompromised host. And fungal pneumonia does not look like primary fungal pneumonia, but it could be. And viral pneumonias. See, you have to have immunocompromised, it could be anything.
Yes.
Yeah, more common will be obviously gram-negative, gram-positive than atypical, viral, bacterial see in the due course. One more thing. You started the patient on NIV. Is NIV better in a patient with immunocompromised patient with type 1 respiratory failure compared to a non-immunocompromised, non-neutropenic patient?
This new Renovate trial actually shows that NIV is better in immunocompromised patient. That was the only subgroup of patient where NIV was found to be indicated.
So our threshold for intubating will be little higher than the routine lot of patient. But this does not mean that if required, they should not be intubated. Still, you have to intubate these patients in time. Do not delay intubation. Immunocompromised, non-immunocompromised, the threshold could be little higher. But if you feel patient requires intubation, you have to intubate. Okay. Even for immunocompromised, if it is a prolonged NIV and NIV failure, then they are intubated, the outcomes are bad. So threshold is higher, but intubation should be again timely.
Yes, sir.
Thank you.
So this was the chest X-ray of the patient. It was showing bilateral infiltrates.
Can you go to the previous slide again?
Yes.
Yeah. So what would be your empirical antibiotic choice? Dr. Mona Lisa already pointed out to the organism. So is your choice of antibiotic empirical complete, or would you have added something more?
This was gram negative covered meropenem has been started, sir. And after coming, this was in the year after coming to ICU, we have added a gram positive cover also, sir.
For this particular patient, otherwise also empirical should be very, very early. You should not delay in such patients, especially neutropenic patient or immunocompromised patient. Meropenem and some gram-positive coverage should have been done from the beginning. Dr. Mona Lisa, would be the dose enough for this particular patient, or would you, for neutropenic immunocompromised, go for higher dose of meropenem?
Even they haven't mentioned about the loading dose. 1 gram stat. The loading dose has not been given at least, and even the doses need to be higher. Sometimes higher in these group of patients.
So the adage what we follow in sepsis normally holds true for neutropenia also, but we are more aggressive. Hit very hard, hit very early, and de-escalate on the right time. Do not hurry de-escalate. So hit very hard. You have to have the complete, at least the routine things which we do for a community acquired pneumonia with high risk of resistance. Meropenem and teicoplanin on the higher dose, probably 2 gram loading I would have given in this particular patient. And then depending on the weight and the creatinine I would have dosed. So you should have given 2 gram, and teicoplanin should have been given from the beginning.
Yeah. Yes.
So, what is the minimum window of like when you should start the antibiotics in these groups?
Within 1 hour.
Yes. Like delay in the antibiotics can have a poor outcome. So early initiation is very important to keep in mind.
Yes.
Dr. Monalisa, there is a question in the chat. We'll take it simultaneously.
Simultaneously, okay.
The question is antivirals at this point.
When would you consider giving antivirals to these
Yeah.
people?
Dr. Pratyusha, you can answer that. Dr. Monalisa will
Uh,
give expert comments.
So as an empirical, antiviral has no role, sir. But in case if there is a more influenza season and if he presents with respiratory, then probably Tamiflu can be initiated or oseltamivir can be initiated, which is a neuraminidase inhibitors. But
Like if
empirically, there is no role of antiviral, ma'am.
Okay.
So the X-ray, what does the X-ray tells us? We'll go very slow.
Okay.
So it is showing bilateral infiltrate. It is there both the sides. So
What type of infiltrates? Localized, lobar, what type of infiltrate?
bilateral
More looks
diffuse.
like interstitial, sir. It more looks like interstitial pneumonia.
So at this point, is the imaging enough with a chest X-ray, or would have you done something more for this particular patient?
CT chest should be.
But since the patient is in shock and also in
Yeah.
type 1 respiratory failure, we would like to first stabilize the patient and then take a call. That is not going to.
Yeah. We would like to obviously
Change the
stabilize the patient before hurrying for the CT. But immunocompromised patient, better to do CT early. Our threshold for HRCT chest is much lower than a non-immunocompromised patient.
Yes.
Why?
Because the presentation, they have a neutrophil will be lower end in the immunocompromised patient. So all the
Yeah.
features may not be there in the X-ray.
And the invasive fungal infections also.
Yeah. And X-ray is often normal in some of the diseases like PCP.
Other differential
times, there will
diagnosis
be no
also.
infiltrates. What else?
Other differential diagnosis also we can rule out with when we do a CT
Yeah.
chest.
And if we want to do a bronchoscopy or a biopsy at times for such particular patients, you will be wiser after the CT. And
Yes.
all the lobes are not shown in the X-ray. We all know that. So for a immunocompromised patient, have a lesser threshold. Even without respiratory symptoms, if you are not able to pinpoint the site of infection in a neutropenic host, it is good to have a HRCT. Yeah. Okay. So have a very low threshold for HRCT. Right.
So the patient has been received in the ICU. So our examination showed the patient is paler and no icterus, no clubbing, no cyanosis, no lymphadenopathy. He has bilateral pitting edema. When we come to the respiratory, there is bilateral air entry equal and auscultation-wise bilateral crypts present both in the anterior and the basal areas. And the patient is brought on NIV support. With that, he was saturating around 94% and his FiO2 requirement on NIV was around 50%. His respiratory rate is around 28 and his pulse rate when we received it was around 100 per minute and BP was 100/50 with NORAD support. And we have done a quick focus. So that focus showed bilateral anterior and basal shreds and LV contractility looked fairly good. And IVC was found to be around 1.5 mm collapsing, more than 50% collapsing. So CNS wise, his E4, V5, M6 and abdomen was found to be soft, non-tender. Bowel sounds were heard. Other spine and extremities, there is no abnormality detected and his skin appears to be normal. So, should we move on to the investigation, sir? So investigation-wise, a respiratory panel was sent, which had flagged RSV. And CBC-wise, he had pancytopenia picture with a HB of 5.5. Total counts was 810. ANC was 430, so that was less than 500. Platelets was 20,000. Electrolytes were normal. He came with urea of 43 and creat of 2.58. His baseline creat was 2.2. LFTs were within normal limits. CRP was 198. His procalcitonin was 1.1. The peripheral smear showed normocytic normochromic blood pressure with leukopenia and thrombocytopenia. And urine routine showed it was normal with no pus cells. USG abdomen done was showing hepatomegaly with grade 2 fatty liver and bilateral renal parenchymal changes, grade 1 and grade 2 prostatomegaly.
So in the whole scheme of things, respiratory panel, what type of investigation was it? What all was it an antigen based and what is it? You have to specify. RSV was positive. What test it was?
PCR.
It is a polymerase chain reaction.
PCR
Yeah, you have
test,
to
which is from the
mention.
nasal and oral throat swab.
What
Is
sort
it the
of
gold? Yeah, Dr. Mulasa, sorry.
What sort of PCR is it, and what all organisms does it cover that were not detected in this plan?
We were covering all the virals and
All the most common virals and atypical bacteria also will be covered in that.
It is from in-house PCR, or is the a panel from the respiratory panel?
No, it's an in-house
Okay.
which we have done.
So, in a patient who has been exposed to healthcare facility, how good is respiratory panel? I'll ask Dr. Shilpa, Dr. Pratyusha, then Dr. Mulasa, your expert comment.
So that will.
This is not a gold standard investigation, sir. PCR testing is not a gold standard investigation.
For a patient who has been exposed to
Immunocompromised patient, it will help us in the initial setting because we start with empirical treatment. So
Very
with the PCR panel, we can come to a more
It is
along the stream
easier.
of the antibiotic. So are we going along antibiotic? Is it more bacterial,
Or
viral?
fungal or
Also
something.
will give us a picture on it.
Madam, any comments on this? Yeah.
The patients who have been exposed to the hospital in the prior couple of months, in them we usually in the respiratory panel we detect a number of organisms. We sometimes come across 3 to 4 bacteria along with 2 to 3 viruses even. So we need to the copy numbers of the organism, the bin copy numbers are also important to see which one of them is significant. And you need not go about treating all of the ones which have come positive in the respiratory panel. So you have to take a call which of them are significant pathogens in your case, it could be, and treat only for them.
So again, the adage goes, don't treat the report, treat the patient. And you have to differentiate between colonizer and infection. Having said that, any immunocompromised patient, if you have a significant number, it will become treatable condition for that particular patient. So always take this with pinch of salt. Immunocompromised patient, I think we should go for panels, but exposure to healthcare, and if it is a healthcare associated pneumonia, the chances of any serious organism becomes less. Yeah. So take it with a pinch of salt. Don't jump to the reports. Yeah. Okay. Rouleau formation. What is it? What does it signify in this particular patient?
This
It is a stacking of the RBCs, sir. So the rolling formation means, and it is most commonly seen in multiple myeloma patients.
Any hypergammaglobulinemia. And generally it will correlate with a higher ESR. And
yes, sir.
Severe inflammation also at times we see rouleau formation. So it is one of the indicator for severe inflammation. Yeah. One more point here. Urine routine was normal.
Yes.
Then why did you send urine culture?
No, the routine might show normal. The epithelial cells only, pus may not be present, but the cultures can grow later. Since it's also
immunocompromised patient,
the
may not
cultures
show
might
the
behave.
significant symptoms. So that is.
Dr. Munasir, do you agree on this? Then just to change, probably I might not be aware. So generally we tend to avoid, but for immunocompromised patient, is it same or is it, so we send it?
We do send it, but if we are not finding any other focus, then we may go ahead.
Okay. Okay. Otherwise, send the relevant cultures only. Otherwise, if you have so many reports, something comes positive, we will be confused. So clinically relevant cultures only should be sent. Pan cultures is not a good clinical practice, even for immunocompromised, I would rather say. So be focused in sending cultures. But okay, this is an immunocompromise at times. I agree. Right. Yeah.
So with all this, we have, diagnosis wise, we have made as acute hypoxemic respiratory failure, severe community acquired pneumonia. So initially we have got respiratory syncytial virus positive. Patient had septic shock, neutropenic sepsis. with ANC counts less than 500. AOC, acute and chronic kidney disease, either could be pre-renal or it could be septic related. And he also had pancytopenia, which is more probably could be his disease progression, or it could be sepsis related.
So probably RSV is the primary etiology, RSV pneumonia and multi-organ dysfunction secondary to a disseminated RSV disease. Will you like to confirm with some investigation, Dr. Melissa? Is it this panel was confirmatory, or would you like to go for something more?
I don't think like in-house PCR, which is showing only RSV, we can totally ascribe it to the RSV symptoms. Any other investigation that you undertook for the respiratory thing?
Sputum he was not producing, ma'am. So initially we couldn't send any sputum gram stain culture.
And BAL in this case could not be done because he was on NIV, and that could tip him off to getting into intubated. So
the CT scan was also not done, if I am not wrong.
that is done after coming. It's done, ma'am.
Okay.
The management part covered it.
So now probably RSV is in one of the differentials. Will you change your therapy now? RSV is in your differentials and one of the top differentials, whatever information we have. What more will you like
still
to?
Cultures are pending, so we'll
No, but
continue to give empirical antibiotics.
no antiviral at this point also?
RSV doesn't require antiviral therapy.
The ribavirin has been, there are some studies which are shown, but it is not recommended for the treatment.
Dr. Mona Lisa, now we have isolated this just for my knowledge again. So legally speaking, we will be wiser not giving anything, or we should give something now?
No, evidence means we do not have any like available antifungals other than the ribavirin, and the availability of ribavirin is also very questionable, and the efficacy is also not very much. So antiviral not.
Okay. Another thing now. Now this patient is immunocompromised. Patient is on NIV. Site of care we already decided on. An isolation facility in your ICU. What type of isolation facility for this particular patient?
Negative pressure isolation.
How is it different from a positive pressure one? And which one is better?
So negative pressure will not allow the outside aerosol air to enter into the room. I mean isolation room. Sir. And so he will not have the contact of other organisms with the patient.
So now there are two things. One is the chances of infection, secondary infection to this patient. Another one is RSV getting as an outbreak in your ICU. So you have to be very, very stringent with your isolation precautions. Dr. Molesa, you want to add something here?
No, that is what we should keep in mind. Like both the patient's organism should not get outside, as well as he should not get the other infections, being immunocompromised. So balance.
So what all infection control precautions would you take?
Isolation, hand hygiene,
single staff allocation.
Standard precaution, yes. Next.
Barrier protection should be followed. And then N95 mask.
Contact and droplet isolation we will do for this particular patient. Okay. Next.
So this patient has been continued to manage with NIV support. He is tolerating NIV, sir. So we have continued with the NIV support, and we've done a focus which showed IVC collapsing. So we have tried giving fluid resuscitation. Initially, fluid resuscitation happened in the emergency. Again, we have given a boluses of fluid, and we were able to come off on NORAD within 1 to 2 hours, sir. So he responded to our fluids. And antibiotics wise, meropenem and teicoplanin and tab doxy was being initiated. And with that antibiotic cover cultures, everything we have sent, and blood products has been transfused, blood products and PRBCs and RDP as required. So we have kept a target of hemoglobin more than 7, and we have transfused the blood products. Patient is also been started on Mucain 300 mcg, and even romiplastin 1 dose was given. So after that, initial blood cultures we have got, sir, that was showing ESBL KP, and initial urine cultures were negative. So this ESBL KP was sensitive to Miro. So we have continued with the same support, and eventually he was improved within 2 days with our NIV support and antibiotic, and he was got shifted to the ward. So
Why did we add doxy?
atypical bacteria cover, sir.
What was in your mind?
There's a still chance of community acquired also coming.
Atypical like mycoplasmas, so that can have. So that is why we have added, sir, tetracycline.
And nucleus GMCSF, I believe, no?
Yes, sir.
So
GCSF.
better to use the generic name in
Generic.
all your case presentation. What is ROMI?
Romiplastin is a thromboplastin stimulator, sir. Increases the platelet count.
Okay. Okay. So GMCSF, how good or how bad? What are the pros and cons of GMCSF in this particular patient or otherwise also?
Yes, sir. It is.
What is the level of evidence for neutropenic sepsis?
The 30-day mortality was benefit was seen with the improvement in the earlier improvement in the neutrophil counts. So
both morbidity and mortality improvement was found, sir, within 30.
I don't think there's mortality benefit, but yes, neutrophil recovery is faster, but mortality benefit was not seen. So you have to be weighing the risk and benefit whenever you give GMCSF for this particular patient. At this point, we would all have given GMCSF, but we have to be very, very careful. And what are the other side effects with GMCSF? What happens to platelets with GMCSF?
No, it has no role on platelet.
Okay. And what is the common side effect, especially in a neutropenic patient after GMCSF? We all have read it. Yeah.
Sure, sir.
What will it increase?
It will increase the total leukocyte count.
So what will happen?
So possibly the disease also.
Have you read about IRIS, immune reconstitution syndrome, which is more common? So the similar phenomena as the neutrophil counts increases, so there are chances of inflammation getting worse, new patches developing in the X-ray, PF ratio might increase. So we have to be very, very careful that it can cause this. Okay. What else could be done? Is there any evidence of neutrophil infusion?
When will you consider any granulocyte transfusion?
Granulocyte transfusion.
We can consider for severe and profound neutropenia, ma'am. Even that is shown beneficial over morbidity. Like it increases the total count. Duration, not very sure, ma'am. Like within how many?
Okay.
Yeah. Sorry.
No,
Granulocyte transfusion. Is there any evidence? There's no major evidence if we want to talk as a class of compound for neutropenic sepsis. Dr. Molisa, any?
You may consider like if there is a profound neutropenia, even like with the appropriate antibiotics for 48 hours not responding, then it may help to some extent, not very definitive.
Okay. So always remember about this immune reconstitution syndrome with GMCSF. And second thing, GMCSF decreases the platelets at times. So we have to be very, very careful. It does not increase the platelet. So we have to be very careful. And this romoplastin 20,000 platelets is the no big deal. We could have probably avoided at this point. Yeah, 20,000 is okay. Okay.
How would you define all the like categories of neutropenia you have dealt with?
It's my neutropenia. It is less than ANC absolute neutrophil count less than 1,500 cells per mm cube, ma'am. So mild will be 1,000 to 1,500. Moderate comes up to 500 to 1,000 cells per mm cube, and severe comes ANC less than 500 cells per mm cubes, and profound is less than 100.
There's a protracted also when the duration
is more than 7 days. ANC being less than 100 for more than 7 days.
Okay. And persistent neutropenia?
More than 48 hours.
Persistent.
If despite the appropriate antimicrobial coverage, the ANC does not recover within 72 hours, it is called persistent neutropenia.
So what is the correlation of ANC with the outcome?
How is it important, like classifying this? How will it help you?
The more severe, the
The
more
more mortality.
patients high risk will come under the high risk category and more prone for infections. So the severity will worsen, the mortality will be higher.
And
So what
longer
are
the
the-
duration, sorry.
You can.
No, please, ladies first.
So what are the other categorizations that you know, like classifications to categorize these patients for the various risk factors, depending upon them?
There is the depending on MASC
Risk stratification, MASCC scoring is there, ma'am. It is a multinational association of supportive care for cancer patient. So they have variables and their score is around 21. So more than or equal to 21, the patients fall under low risk category. And MASCC score less than 21, patients are being considered as high risk. So this is one of the scoring system which we use to do risk stratification.
There's also a clinical index, stable
Stable
neutropenia,
is also there, and
the grading of the risk category. The MSCC score just gives us the high risk category. It does not grade it into the further finer details, but the clinical index of stable febrile neutropenia gives us the category low, middle, and high risk category.
So what was the like? How sensitive is this score? How specific is it? Like in categorizing the patient.
The MSSC score is not the 35% around is the sensitivity, because it does not take into the conditions, the other condition. Only the COPD condition is taken into the picture in that, and other clinical condition of the patient is not there. Also, the counts are not taken into the consideration in MSCC score.
No, it is not that less specific or sensitive. It is like in the range of 90s, the sensitivity and specificity for categorization of these patients. Okay.
So the ANC, lower it is, worse the outcome. More prolonged neutropenia, worse is the outcome. Why?
The chance of infections, opportunistic infections add on.
Yes. So immunosuppression and the duration of immunosuppression both are important. And the third thing which is important is exposure. And this patient has been going to the hospital, so is exposed to everything. What other diagnostics you should have done for microbiology till this point? You haven't worked up for fungus so far.
No, this patient we have started empirically with a gram negative and gram positive. So we found that there is an improvement.
No, still, but for the immunocompromised patient, it can be anything, right?
1,3 beta D glucan can
Yeah,
be
some beta D glucan or galactose, both or one at least we should have sent. Yeah, this should be a there is nothing known as routine investigation, but for this particular patient, it would have fulfilled the criteria to send it. Okay.
The patient was shifted to the ward in 2 days. Like after 2 days of symptomatic improvement. So it was like almost how many days after the admission? 5 days.
23rd. No, after admission.
So like after 2 days of admission, he was shifted to the ward.
Yeah, yes, ma'am.
The respiratory isolation and all that barrier precautions, they were.
It is there in the ward also. We have maintained the same.
There's isolation and
the transport.
That you have not mentioned, like shifted to the ward. It like it goes against what you all we have discussed, like no precaution.
No, he shifted to an isolation ward.
There are few queries about this immune reconstruction inflammation syndrome, IRIS, or neutrophil recovery syndrome. Paradoxical, while the ANC is increasing, there could be paradoxical shadows or worsening PF ratio. This is the commonest presentation which we encounter. Dr. Monalisa, what else can we see in IRIs? especially from critical care point of view.
Pardon, sir, I couldn't understand. What?
What else could be presentation of IRIS for a patient?
Okay. Like there can be paradoxical worsening after like a short period of improvement of the symptoms. There can be a like sudden worsening of the symptoms, like the fevers coming again, the respiratory parameters worsening, and all. This could indicate towards IRS.
Yeah. So always keep this entirety in mind whenever the patient is suddenly deteriorating after the ANC has started improving. Okay, yeah. Dr. Pratisha next. Day 5.
On day 5, patient had sudden onset of fever, hypotension, and shortness of breath, for which patient was shifted back to ICU. And repeat cultures of the blood was sent. Sputum gram stain and culture sensitivity was sent. Antibiotics were escalated in addition to meropolymyxin, teicoplanin, and micafungin was added. NIV was again initiated, and noradrenaline was started to maintain a MAP of 65. When the patient came, patient was tachypneic with the rate of about 25, and also in type 1 respiratory failure with there was a shock component also. 50 was the BP. The CBC which showed was done, which showed a total count of 740 with ANC of 300 and HP of 7 and platelet of 30,000. So ABG showed type 1 respiratory failure with 45 PO2 and -3 base excesses with 7.3 pH, lactates of 0.2 millimoles per liter. So we got a CT.
One back, last slide again. So whenever we have a new patient with an infection, we always have to risk stratify for MDR, especially with exposure to healthcare facility. Okay, you can use whatever tool you want to, but you have to do it at least subjectively. Better to do it objectively also, but there are various tools which are available. This particular patient who was exposed to healthcare facility, polymyxin we would have started from the beginning. If the patient was not exposed to healthcare facility, it was okay, but exposure to healthcare facility in a neutropenic patient, there is no reason why should we be scared about polymyxin. So our polymyxin should have been upfront in this particular patient or any other patient who is developing healthcare associated infection. So do not shy away from polymyxin despite guidelines are still shying away from polymyxin. If healthcare exposure is there, the chances of carbapenem resistance could be 50, 60, 70 or even higher. So right antibiotic has to be started. Empirical antibiotics should be right in this particular patient. Otherwise, the mortality will be very, very high.
The patient had a Klebsiella pneumonia. So for the Klebsiella pneumonia, what would be the drug of choice if you're suspecting a MDR bug, like carbapenem resistance?
ESPL.
Yes.
Okay.
It is a ESPL which has come, but it is like somehow the patient has worsened, and you are still suspecting that the Klebsiella would be the cause. So what are no brand name? What are the combinations? So what alone that would be sufficient in considering the resistance patterns?
also.
What are the what test do you have to recognize what are the resistant genes and all? How will you know?
Biopan sepsis panel we can send, ma'am. So that
What does it include?
That include this resistive gene testing can be done.
Sepsis panel. We got expert carbar thing which determines the resistance genes of this Enterobacteriaceae.
Yeah, the type of beta lactamase, which is the gene, can be further in case of.
So this expert carbar that can help us like mostly in this Enterobacteriaceae, we can determine the NDM, VIM, and the metallobeta-lactamases that are mostly like most of the isolates of our country have these. So we need to give a combination of ceftazidime avibactam with aztreonam, especially for this Klebsiella. So adding a polymyxin, and there have also been various studies which have shown that the outcomes of the patients who were given the polymyxin or colistin versus the ceftazidime avibactam had a poorer outcome. So the drug of choice somehow is not appropriate in this case, knowing that it's a Klebsiella pneumonia. Okay.
Yeah. So firstly, our empirical drug choice should have been right and not definitive therapy. So we should not have compromised. Ideally, though, we should have covered for all the resistant carbar from the very beginning.
Yes, knowing like after the isolate came, even if it is a ESBL, because knowing the epidemiology these days, 60 to 70% of the organisms Enterobacteria are CREs. So even then, if it comes ESBL, you should send it for the expert carbar if it's available, so that you can know the resistance genes, and then accordingly add the antibacterial.
Otherwise, also you must cover Pseudomonas for all
Yes, sir.
neutropenic patients. And we don't go for talk about double coverage of Pseudomonas normally because we have better agents, but immunocompromised or neutropenic patient, I would probably go for double cover. Dr. Mona Lisa?
Earlier, the thing of double coverage was there, but these days the antibiotics double coverage is not that recommended for this
Even for
negative coverage.
immunocompromised.
Okay.
So, empirical antibiotic, as we discussed in the beginning, hit very hard. Do not be lenient about antibiotic choice for a neutropenic patient. Okay? Fever in neutropenia, treat it as sepsis. Sepsis in neutropenia, treat it as septic shock. You have to be very aggressive. It's a medical emergency. It's the worst kind of sepsis. Why is it pathophysiologically different from a non-neutropenic sepsis? What are the differences? We missed that part. Why is the outcome so bad in neutropenic sepsis? Yeah,
Because
easy. You know
no,
the answer.
There's no
it's not neutrophil.
immunity to fight
Immunity
against
Yeah.
the bacteria.
No immunity. Okay, the line of defense is missing. Neutrophils are not there. Then there are no classical signs. So we diagnose late.
yes.
Worst
And
one.
fever could be the only sign. Otherwise, you have to look at subtle cues. You have to be like a detective to find the focus of infection. We have at times found a apical tooth abscess. We have found perirectal abscess. So you have to be very aggressive in diagnosing the source of infection for a neutropenic patient. We can often miss. And subtle signs you have to catch. There could be rapid progression of disease because there is no immunity. Once the patient gets an infection, it could be very fulminant, especially pneumonias and multi-organ dysfunction phase. They are very, very fulminant.
Even the commensals can cause, like due to the barrier disformation of the gut mucosal integrity is lost, and oral mucositis and perianal region also the mucosal increase can be there. So specific tools should be used.
Fever might be missing, and hypothermia is literally what I don't know the data, but we see more of hypothermia in an immunocompromised patient compared to a non-immunocompromised patient. As Madam pointed out, translocation from the gut, endotoxemia, and bacteria have to cover for those agents also. What do we call it? What injury? Mucosal barrier injury. What are the other causes of mucosal barrier injury? Common causes which we see. It could be shock, any shock, radiation, chemotherapy, any severe disease, burns. Yeah. Okay.
Even in these group of patients, only the oral temperature should be measured. Even the measuring the rectal temperature could also cause a disintegrity of the mucus.
There are few questions, we'll take them along because it was relevant to this slide. Dr. Mona Lisa, first let Dr. Shilpa and Pratusha answer. For MDR, Klebsiella, ceftazidime, avibactam combination, infusion simultaneously and avibactam combination. Infusion simultaneously or one after other, Dr. Pratusha?
Together we have to do so.
How much time?
Ceftazidime, avibactam together with Astrianum together we have to try.
How much time?
Avibactam will be the
Same common.
And when you give the Astrianum, it will be given as a synergist. So it will be given in two different lines.
Two infusion, but simultaneously.
Simultaneously we have to give it.
So the answer is you have to give both simultaneously over 3 hours. The loading dose could be over an hour, but the other doses have to be, maintenance dose have to be over 3 hours.
Yeah.
Another question from Dr. Manan Raina. Dr. Mona Lisa, you can probably answer this. Should atypical coverage be started right from the onset or not? Neutropenic pneumonia.
Right from the onset, we may consider in this patients who have the respiratory presentations, mostly it can be a atypical organism as well. So we can go ahead, but after having a definitive diagnosis.
Slow and steady.
Okay.
We have to be aggressive only with treatment, otherwise slow and steady. In life, you have to be slow and steady. So what does the CT tells us?
So there is
We also jump when we are not very certain about things. When our seniors, we also jump. So, but this is an easy CT.
There's a subpleural consolidation which is seen in the
in the
basal.
peribronchiovascular areas, there is subpleural consolidation is there, and there are multiple ground glass opacities also present, sir. And in the basal area, we can see there is some fibrotic opacities which are present in bilateral basal lung fields.
So what would be your differential? Is it pathognomonic or something of? No.
No, sir.
No, this is telling us pneumonia,
General,
probably not
infective,
pathognomonic of anything. Yeah. Okay. Any immunocompromised patient with pneumonia, we should try to have some invasive representative sample. We have to take risk at time. Okay. At times we have to take, when NIV people do bronchoscopy, but it should be a skilled bronchoscopist, a senior person, quick in and quick out, or at least an aspirate must be there. Have a representative sample.
Yes, sir. This day 5 when he deteriorated and presented to us, we had he is producing sputum, sir. So that we have sent for both the gram stain and culture sensitivity. So shall I go ahead, sir?
Yeah.
So CT which was done that showed this ground glassing and that peribronchovascular areas, and there is also fibrotic changes in bilateral lung fields. And that sputum culture which we have sent that has come as Acinetobacter, sir, this time. It is carbapenem resistant. So we have continued him with polymyxin, and gradually his like NIV support, and we have able to, initially it was a continuous NIV, we were able to come down to intermittent. And later, his ANC counts were also gradually improving. So the physio and other parts have been, incentive spiro has been continued for the patient. So with this antibiotic cover and other NIV support, he eventually improves. And we have shifted him to the ward back again. And later, he was doing fine. So he got discharged also, sir, on day 8.
On day 8?
Day 8, day 9. I'm not sure from the ward. Sir.
On the day 5, he was having severe hypotension, and by
day 8, after 8 days. Sorry. With us, he was there for another 4 to 5 days, ma'am. So after that, he got shifted to the ward.
So what are the guidelines regarding when do you need to come down on the antibiotics, de-escalate? Like what is the duration of antibiotics in these group of patients?
So it all, like usually it is 7 to 10 days, ma'am, but it depends upon case to case. First thing is we have to have a clinical stability. Like he had a hemodynamic issue, he had a shock. So that should be stable, he should be. And they say ANC counts also to be improved, ma'am. It should be more than 500. And so
we can de-escalate based on the culture sensitivity.
Culture
sensitivity to the specific antibiotic, and once the febrile neutropenia has subsided for more than 48 hours and the ANC is in an improving trend, then
we can de-escalate.
Persistently more than 500 and in an improving trend, we can come down on the antibiotics.
Okay. Is there any difference for the high-risk neutropenic patients and the low-risk neutropenic patients, the duration of antibiotics?
Low risk, usually for 5 days, we will be giving antibiotics, ma'am. For the high risk, we can consider giving antibiotics for 7 to 10 days. And if it is other any gram positive, it can be up to 14 to 21 days also in MRSA patients.
Depending upon the organism that you have.
Organisms.
The duration depends. And after the recovery of the neutrophils, or at least 48 to 72 hours of apyrexia, then you can consider. Not very hastily you need to come down.
Yes.
So don't be in a hurry to de-escalate the antibiotics in this particular subset of patient. Okay. Generally, they require much longer. Crab with an immunocompromised patient, I would have given for at least 2 to 3 weeks.
No, like this patient in day 8 is getting discharged. I somehow like he will again come again with the infection, like being partially treated, I suppose. Like if you are discharging this early.
So just to recapitulate the main points, uh, this was a neutropenic sepsis, MDR gram-negative infections. RSV could have been a co-infection, difficult to say. There was multi-organ dysfunction. Always treat bone marrow depression and cytopenias as one organ system. So renal impairment was there, and cytopenias and shock. Three organs actually were involved. Baseline, your MMRC was grade 2 to 3. So utilize this baseline MMRC for triaging and admission criteria. Severe neutropenia, you have to be very aggressive with the diagnostics, CT scan, and representative cultures, and other antigen antibody based tests should be used leniently. You should not be miser as compared to. Always risk stratify your patient who has been exposed to healthcare facility, and be very, very hard in hitting immunocompromised patient with the right antibiotic. Hit hard, hit very early, and generally a longer duration is required for an immunocompromised patient. Recovery of neutrophil count was probably the turning point in your patient. Dr. Mona Lisa, any take
Yeah, in
home?
these group of patients, even we may go ahead over investigating them rather than delaying the investigations and later having a poor outcome. So the biomarkers that are there, if suspecting a fungal infection, they can help. If we are suspecting like the beta D glucan can also like help us in whether it's a fungal or even for the PCP, the beta D glucan would be high. So you can have an idea whether it is so. Even if you don't have the PCR or anything available at your hand, they can give you an idea. So over investigating the like sometimes helps in diagnosing the pathogens early and giving the appropriate treatment. And it's like the Occam's razor does not apply. The patient, like your patient, had 3 pathogens. The RSV was there, then it came the CLEB and then the acinato. So it is not that one pathogen can explain everything in these group of patients. So you should keep your eyes open to see, like, to pick up the various pathogens that can be harboring. Given the immunosuppressed status as well as multiple hospital exposures and prior exposure to antibiotics, they are more so at the risk of multiple infections. So
Hand over to Dr. Ravi. Somebody has asked, Dr. Shamdev has asked for the present recordings. Probably these are available on your YouTube. Na?
yes.
You are mute, Dr. Ravi.
Yes, sir. So these presentations are available in Facebook for reviewing again, sir. But now, second couple of things from my
The
side, sir.
volume is low.
Can you hear me, madam?
Yes, now it's.
Yeah. So these presentations are available in Facebook page. Actually, you can go back and review whenever you want, and even available on YouTube also. So a couple of things that would be, probably, one thing which we could have done earlier was a PCP or a CMV, because these are quite common in these immunocompromised patients. So early, PCR, especially when these patients were coming from a hospitalized setting. So probably rather than looking at, although community acquired organisms are quite common, so we also tend to look at hospital acquired pathogens which will not be covered in the URTA panels. So if possible, like what Yash sir has suggested, high risk bronchoscopy can be done under HFNC or NAV cover. Or if the patient is able to produce a sputum, probably sending a sputum for a panel, in different hospitals, it comes with a different name. What we have is something called an LRTA panel, which will cover typical, CLEB, acinato, all these organisms will be covered. Along with that, probably PCP, CMV should have been tested is what, I would have suggested actually. The second thing is, the Avibactam aztreonam combination actually. So probably the more and more literature is coming towards, use of plain Avibactam along with aztreonam, which we are practicing right now. And always, the problem is, Avibactam should be given much earlier than the aztreonam actually. Otherwise, your monobactam will be lysed. So start off Avibactam first, then start aztreonam. And the dosing is also quite different. Actually, 1/3 of the dose should be given as a bolus, and the rest 2/3 should be given as an infusion to have a sustained, infusion level, sustained drug therapeutic level actually. So these are my two add-on points, and I think there are a couple of questions actually. Yeah, that's it. So anything else from Dr. Pratyusha and Dr. Shilpa
Yes. No, sir.
that you wanted to ask the examiners?
Nicely presented. Sorry for bothering you in between, but
Yeah,
that
no,
is it.
like
That is the way you should have the real world experience. And thank you, Dr. Mona Lisa, for your expert comments. And always see Dr. Pratyusha, Dr. Shilpa, whenever you write your notes and see your patient, always have a multidisciplinary approach. Such patients and otherwise also involve the ID consultant, involve the pulmonologist. Don't be the sole lighthouse.
Yes, sir.
Always involve people. Yeah.
So thank you, Dr.
Thank you,
Pratyusha, Dr. Shilpa, for bringing up this case and presenting it. And thank Yash Javeri sir, who has been our constant support, for coming over for these master classes, and Dr. Mona Lisa madam, for giving her inputs from the ID perspective. Thank you both of the examiners, for guiding them. So
Pleasure.
thank you, and we'll end
Pleasure.
this session.
Thank you. Good evening. Good
Thank
night.
you.
Bye.
Thank you.
All the best, Pratyusha and Shilpa.
Thank you, ma'am. Thank you.
Bye.